pain radiates to the back. Why the patient of pancreas pathology, when they sits up or lean forwards, their pain reduces. You know why? Because by bending the vertebral column with concavity towards the front direction, you are increasing the retroperitoneal space, and therefore the pressure on the pancreas is getting reduced. So pancreatitis have retroperitoneal radiation of the, radiation of the pain to the back only in 50% patient. Remember, it is not that 100% patient of pancreatitis will have radiation of the pain to the back. Typically, you ask, how commonly do they have radiation of the pain to the back? It is 50%. And forward leaning position actually reduces the pain. I explained why. From epigastrium to right iliac fossa, perforated peptic ulcer. You know why? Because the perforation of the peptic ulcer occurs. You know there is a hepatorenal pouch of Morrison there. Hepatorenal pouch of Morrison, if you see extension, it extends to the right paracolic gutter. Therefore, right iliac fossa is the bottom of the right paracolic gutter. So therefore, there will be pain coming there. Look at the referral to the inferior angle of the scapula biliary colic, to the shoulder subphrenic abscess biliary pain, loin to groin renal colic, lesion of the stomach and duodenum and jejunum to the epigastrium, ileum and appendix to the umbilicus, because ileum nerve supply is T10, appendix nerve supply is T10, therefore going to the umbilicus, that is the dermatome there. So that dermatome of the umbilicus is supplied by T10, whereas you know up to T9, T6 to T9, stomach nerve supply, parasympathetic and sympathetic nerve, mainly sympathetic, and the sympathetic nerve is the nociceptive nerve, and T6 to T9 is the nerve supply of the skin of the epigastrium. Therefore, you get referral there, and colon hypogastrium. Aggravating factor, gastric ulcer, food, stooping forward reflux esophagitis. Cholecystitis, fatty food, because fat increases gallbladder contraction. Rolling aggravates peritonitis. That's why peritonitis patient will be lying standstill. They don't want to move. Inspiration increases the pain because of the diaphragmatic movement. So any structure below the diaphragm, particularly the pleura and all those which are also over the lung, inspiration will increase the pain. Relieving factor, vomiting relieves pain of intestinal obstruction because it is reducing the intraluminal content. Leaning forwards will decrease the pain of pancreatitis. I explained to you why. And food reduces duodenal ulcer pain. People have studied the mechanism. Why should food reduce duodenal ulcer pain? Because we all know that stomach empties in about 2 hours. If somebody eats now, the gastric emptying of solid is around 90 to 110 minutes. But if you eat, immediately duodenal ulcer pain got relieved. The reason is there was a beautiful study published in Gut where they found that pain of duodenal ulcer is not arising from duodenum, but from antrum of the stomach because of the associated gastritis. But obviously in a clinical session, I don't want to talk about that study. So abdominal causes of acute abdominal pain, abdominal wall, trauma and infection of the muscle, inflammation of peritoneum, hollow visceral obstruction such as small intestinal obstruction, large intestinal obstruction, biliary tree obstruction, ureteric obstruction, vascular causes thrombosis or embolism, vascular rupture, sickle cell anemia causes sickle cell crisis that leads to severe pain, and distension on the visceral surface such as hepatic metastasis, hepatic abscess, and so on. Whereas other causes, remember, systemic diseases can present with abdominal pain as an acute emergency. What are these? Diabetic ketoacidosis may present with epigastric pain. Porphyria is well known to present with abdominal pain. Lead poisoning is well known to cause abdominal pain. Uremia can present with abdominal pain. Extra abdominal causes such as coronary artery disease, radiculitis, torsion of testicle, pneumonia, and herpes zoster. When we ask people or students, what do you mean by colic? And many a time, unfortunately, we don't get a right answer. What is a colic? Colic occurs because of obstruction to the hollow viscera. Now, why does colic occur? Colic occurs because there is an obstruction to, let us say, intestine. Intestine contracts to overcome this obstruction as shown here. Now, when intestine tries to contract to overcome this obstruction, obviously this leads to increase in the intraluminal pressure of the intestine. There is a relative ischemia, and that leads to pain. What happens is intestine contraction. Obviously, muscle undergoes fatigue because no muscle can continue for very long time. When muscle undergoes fatigue, there will be a decrescendo like this. And then after the muscle again gets back the energy, there will be again, it is trying to overcome the obstruction by contraction. So typically intestinal colic will be crescendo, decrescendo pain. The crescendo phase will last for about 5 to 10 minutes. You know why? Because the duration of migratory motor complex of the intestine is 5 to 10 minutes. So what happens is that's why it lasts for 5 to 10 minutes. Then there is a decrescendo phase. Why decrescendo? Because the intestinal muscle got tired. It has to get back its ability to depolarize by moving the sodium ion out and the potassium and making the sarcolemmal membrane again negatively charged inside, because this is repolarization. That repolarization phase takes some time, and that's why it is unable to contract for this period, so patient gets relief. So therefore, intestinal colic is typically midline. It is a visceral pain, so poorly localized. It is crescendo and decrescendo. Crescendo lasts for about 15 minutes. Decrescendo lasts for a variable period of time, again 10 to 15 minutes. And there is a repeated occurrence of this because it is not able to overcome the obstruction because there is a tight luminal narrowing. Now, obviously, whenever there is a visceral pain, there are autonomic associated symptoms. What are autonomic associated symptoms? Palpitation, feeling of impending doom, perspiration or sweating, okay? And this is intestinal colic. Now, biliary colic, is a misnomer because biliary colic has a crescendo, then plateau. And even if there is a decrescendo, maybe half an hour to 1 hour, after that it doesn't come back normally again. So intestinal colic is a true colic. Biliary colic is not a true colic. It has a crescendo. It has a decrescendo. It has a plateau, but it is not repeated like intestinal colic. This is the answer what one wants from you. So ureteric colic, severe colic pain, starting in the loin, radiates to the groin, hypogastrium, genitalia, and medial side of the thigh. Why is it so? Because there is a nerve which is going behind the kidney. This is called genitofemoral nerve. The irritation of genitofemoral nerve, which passes through the femoral canal, and then it supplies the genitalia such as scrotum or labium in case of female, and the medial ellipsoid area, a tongue sepid area in the medial side of the upper part of the thigh. That's why they typically have pain in the groin, in hypogastrium, in genitalia and middle side of the thigh. And some patient may not even report to you that the pain is in the loin. He can say, my pain is in the scrotum and the medial side of the thigh. It may be because of a ureteric stone, and it may be accompanied by burning, micturition, and hematuria. So therefore, to localize the pain, you must ask for the associated symptom. Now, visceral and parietal pain, what are the differences? And this is typically we ask in the bedside. Visceral pain is dull, crampy, burning, gnawing, poorly localized. Parietal pain is sharp and well localized. Onset is more gradual with visceral pain, sudden with parietal pain. Sudden midline site in visceral pain, whereas lateralized in parietal pain. Secondary autonomic feature, as I mentioned to you, are the feature of the visceral pain, but not so much with parietal pain. Effect of posture. Patient with visceral pain move around in effort to relieve the discomfort. So if somebody is tossing in agony in the bed or on the bed, this patient does not have parietal pain. This patient has a visceral pain. Whereas if somebody doesn't want to move, remain stand still, even the abdomen is not moving with respiration, this is peritonitis, because parietal pain gets aggravated by movement. Okay, so these are the differences. Also, our patient had two episodes of recurrent subacute intestinal obstruction. So when you are in bedside, we will ask you, do this patient have proximal gut obstruction, mid gut obstruction, or distal gut obstruction? And you have to see the difference. Site of pain, epigastrium in proximal gut, you know why? Because foregut extends up to the ampulla vata, and the nerve supply of the foregut is up to T9, and that is the nerve which supplies the epigastrium. Midgut obviously extends from the ampulla vata to a point between the right 2/3 and the left 1/3 of the transverse colon. Okay, now that nerve supply obviously T10, T11. Therefore, it is localized around the umbilicus, that is the area which is the dermatome or the nerve supply for the umbilical region. And the distal gut pain will be hypogastrium. So remember one thing, if somebody is having colonic, let us say transverse colonic pathology, don't expect the pain to be in hypogastrium. The pain will be in umbilicus. Whereas if somebody is having left colonic pathology, descending colon or sigmoid colon, the pain will be hypogastrium. Proximal gut, vomiting is a prominent feature. Abdominal distance and borborygmy much less. You know why? Because stomach is already quite distensible, and stomach doesn't have that sort of too many bowel loop to show you visible peristalsis, a movement of the fluid within a narrow tunnel causing borborygmy. Whereas midgut, abdominal distension is prominent, borborygmy are there. Distal gut, abdominal distension is very, very prominent, and borborygmy are there. But let me tell you, distal gut distension will be peripheral, proximal gut, midgut, not proximal gut, midgut, the distension will be central, and proximal gut distension, if at all there, will be in the epigastrium. Obstipation is not a feature of proximal gut obstruction, but of distal gut obstruction. And visible peristalsis is more prominent with midgut and the distal gut, not with proximal gut. Now, this is the pain side. Proximal gut, epigastrium, midgut, umbilical, distal gut, hypogastrium. Don't forget this. And people will ask, why is it so? Remember the dermatome, remember what is foregut, remember what is midgut, what is hindgut, embryological. So let us come back to our patient. Past history, 5 children, postmenopausal for 12 years, nothing significant. General examination, pallor mild, rest NAD, no lymph node and lung. Now we did inspection of the abdomen, no abnormal. Palpation, no peritoneal sign, no hepatosplenomegaly. Now on examination, there is a lump. Lump I have drawn there. This is right. This is like involving part of the hypogastrium, part of the lumbar region, and part of the right iliac fossa. It is formed around 10 into 10 centimeter. Margin are distinct all around, non-tender, no lobulation. It is freely mobile, not bimanually palpable, not ballotable. Renal angles are free, and it becomes more prominent in knee elbow position. These are very, very important. Like I will tell you how to differentiate retroperitoneal lump and intraperitoneal lump later. But let me tell you, percussion, no free fluid, auscultation, no rub and bruit. Now let us come to the abdominal examination analysis. Our patient did not have anything in inspection, but they are finding in palpation. So inspection revealed nothing. But let me tell you, what can you see in the inspection? This is Caput medusae. This is not talking about this patient. Now, typically, if you come to an examiner with a Caput medusae, and obviously this patient has portal hypertension, examiners will examiner may ask you, now if you think this is portal hypertension, is it pre-hepatic? Is it hepatic? Is it post-hepatic? That means pre-hepatic means extrahepatic portal venous obstruction. Post-hepatic means cirrhosis of liver. Post-hepatic means Budd-Chiari syndrome. Obviously, your answer is this is either hepatic or post-hepatic, because in extrahepatic portal venous obstruction, you cannot have anterior abdominal wall vein. The moment you say that, examiner will ask you, why is it so? Why is it so? Now, I tell you, today I'm not going to talk about it because today my patient is somewhat different and I have only maybe 20 minutes left. But maybe if I get an opportunity next time, I will talk about it. Now, remember, if you have got a patient who have an abdominal lump, this was a classic teaching in when we were doing DM by Professor S.R. Nayak. He was a great teacher. You give lot of importance to the lump while analyzing. Lump is one which you have seen, you have palpated with your own hand. History is given by the patient. So if there is a discordance between the history and the finding, now I'll give more value to the finding and less to the history. So if you got an abdominal lump, give lot of value to the abdominal lump. How to give value to the abdominal lump? Let me come to it. This is, you should know whether the lump is retroperitoneal or intraperitoneal. How to do that? Retroperitoneal lump are deep, not easily palpable. Intraperitoneal lump are superficial and easily palpable. Margins are poorly defined with retroperitoneal lump, well defined with intraperitoneal lump. Movement with respiration is not there in retroperitoneal lump except kidney lump. You know why? Because kidney is covered by fascia of Gerota. And fascia of Gerota now give extension to include even the adrenal gland above the kidney. And then there is a phreno-renal ligament. So the kidneys are connected to the diaphragm. So therefore, kidney is a retroperitoneal lump, but it moves with respiration. So movement with respiration otherwise not there in retroperitoneal lump. Intraperitoneal lump moves with respiration. Intrinsic mobility, like our patient had a lot of intrinsic mobility. I told you that it was freely mobile. Intrinsic mobility is a feature of intraperitoneal lump, not of retroperitoneal lump. Ballotability. Ballotability means you put two hands, one anteriorly, one posteriorly, then push the lump from the posterior side. The lump will touch your anterior hand and will go back. This is ballotment. Now, ballotability is a feature of retroperitoneal lump, not of intraperitoneal lump. Bimanual palpability is usually a feature of retroperitoneal lump, not intraperitoneal. Knee elbow position, retroperitoneal remains the same, whereas intraperitoneal falls forward. Like our patient finding was that on knee elbow position, lump was falling forward. Renal angle may be full in retroperitoneal. In our patient, it was empty. So therefore, our patient had empty renal angle. It was falling forward in knee elbow. It was moving intrinsically very well. So this is an intraperitoneal lump. Percussion over lump in retroperitoneal is resonant because retroperitoneal is behind the peritoneal reflection. I'll show you, and in front of that is the bowel, whereas intraperitoneal will be dull. Now let us come back to that. So this is the peritoneal reflection which you must know. So this is the peritoneal reflection. The peritoneum comes like this. This is a parietal peritoneum. It extends up to the bare area of the liver posteriorly and then covers the liver. Then it comes as a lesser omentum. It covers the stomach. Then anteriorly it comes like greater omentum. This is called abdominal policeman. That's why omental lump are very superficial and freely mobile. Then it goes backward and encircle the transverse colon, and then it extends as a transverse mesocolon. Then it covers the anterior surface of the pancreas, then goes in the retroperitoneum, covers the caudate lobe of liver, and then obviously bare area is left behind. This is called lesser sac. So lesser sac is behind the stomach, behind the lesser omentum, inside the greater omentum, and this is called the greater sac. The rest is called greater sac, and this is the small bone. So what are the retroperitoneal lump? Retroperitoneal lump are behind this retroperitoneum. So pancreas is retroperitoneal. Third part of the duodenum is retroperitoneal. A lot of muscles are in the retroperitoneal area. Nerves are in retroperitoneum. Okay, lymphatics are in the retroperitoneum. Aorta is in the retroperitoneum. So vertebral column obviously is retroperitoneal. Now what happens is this is retroperitoneal, and anything in front of that is intraperitoneal. Okay. Now again, when you look at the lump, Again, you remember the organs which lie in each quadrant, because when you are palpating lump, what could this lump be? Like what could be our patient lump? Our patient lump could be arising from the cecum, yes. It could be arising from the appendix, yes. It could be arising from the ileum, yes. Since a female patient, it could be tubo-ovarian. It could be arising from even all the fatty tissue there, because over the ilium, the bone, you have a lot of fats, and there are iliopsoas muscle. It could be arising from those iliopsoas muscle. So if I know all the organ that are there in that location, then I'll be able to interpret my lump better. Okay. Now, also, somebody may ask you, is it a parietal lump or is it a intra-abdominal lump? For that, you do what is called leg lifting test and head raising test. So on head raising and leg lifting, what will happen is, whereas intra-abdominal lump will not be prominent. So this is what it is. Now, palpation method I will not talk about, because you have all come from MD. So therefore, you have read Hutchison, you have read Chamberlain, you have read McLeod. So in percussion, you look at fluid thrill, you look at shifting dullness, you percuss the trough space, you do a sculptopercuss. So what is fluid thrill and what is shifting dullness? Fluid thrill means you put on the anterior, like hand like this, in the middle of the abdomen, then tap in one side and feel on the other side. If there's a lot of fluid, this fluid will give that tapping, transmitted tapping on the other hand. And this means there is a large volume of fluid. Whereas if you have small volume of fluid, this will not be there. So in small volume fluid, what you have to do is you will have to do shifting down. Shifting dullness, you all know the method. But if you have very little fluid, the minimum amount of fluid is detected when you percuss while the patient is in knee elbow position. So up to 100, 150 ml fluid can be detected by that. Okay, trough space, it is a space bound superiorly by sixth rib, laterally by left mid-axillary line, inferiorly by left costal margin, and trough place is normally resonant, but it can be obliterated by splenomegaly, left pleural effusion, and CS stomach. Now, any patient with abdominal lump, do not forget to examine external genitalia, parrectal examination, and supraclavicular region. Because if you read belly and lump, it is written that if you do not put a finger inside the rectum, you may put your foot inside it. That is a very important dictum. So if you have an abdominal lump, never forget to examine external genitalia, do parrectal examination and supraclavicular examination. Now these are, let us recapitulate where all these lump could be anatomically. So right hypochondrium lump can be right lobe of the liver, gallbladder, part of the duodenum, hepatic flexure of colon, part of the right kidney, suprarenal gland. Because what happens is sometimes people forget suprarenal gland, sometimes people even forget hepatic flexure. Okay, right lumbar region, ascending colon, lower half of the right kidney, part of the duodenum and jejunum. Right iliac fossa, what could be the lump arising in the right iliac fossa? Like our patient, cecum, appendix, lower end of the ileum, right ureter, right ovary in female. You see how important it is that when I was teaching you, I even forgot to mention right ureter. But obviously our patient did not have any renal symptom. But still, I should have remembered. Epigastrium, pyloric end of the stomach, duodenum, pancreas, aorta, and portion of the liver. Umbilical, omentum, mesentery, transverse colon, lower part of the duodenum, jejunum, and ileum. Hypogastrium, ileum, and bladder. Left hypochondrium, stomach, spleen, tail of pancreas. Remember, tail of pancreas moves with respiration. This was elegantly showed by a paper from PGI Chandigarh. I think Dr. Deepak Bhasin is one of the authors. And obviously, tail of pancreas extend inside a ligament, which goes from the pancreas to the spleen. And that's why tail of pancreas moves with respiration. Splenic flexure of the colon, upper pole of the left kidney and suprarenal gland. Left lumbar, descending colon, lower half of the left kidney, parts of the jejunum and ileum. Left iliac, sigmoid colon, left ureter, and left ovary in female. So these I've already said. Now, differentiation between GB, liver, and kidney swelling, I will not talk today because our patient did not have such a lump, which I have to differentiate all this. So let us come back to our patient. Her hemoglobin was 12 gram per second. TLC normal, platelet normal, ESR female normal is 30, she has 38, much, not much. Total bilirubin was 0.3, total protein albumin normal, SGPT, SGOT normal, creatinine normal, urine microscopy negative. This is radiology. Now it shows from multiple internal septa, no calcification, free fluid was present. So this is the ultrasound. So the ultrasound showed that there is a lump in the right iliac fossa, which had multiple internal septa, no calcification, free fluid present. Somebody did a barium mail follow through outside, and what you see here, yes, this is the iliac bone. Now look at this, appendix is quite shifted upward. Even the ileum is going upward to actually reach the cecum or ileocecal junction. And there is a soft tissue shadow here. So there is some pathology here because the cecum is not sitting over the ileum, iliac bone. And now what happens is this is the ileum, that is large parts of the intestine. This is barium enema. This is the CT scan of abdomen. Somebody wants to pinpoint or raise this is the CT scan. Now somebody wants to give the diagnosis. Anybody wants to give the diagnosis now? I haven't written.
So if you have anything to say, you may type it on your chat box.
Okay.
Any attendee, you want to say anything, you can type on the chat box. Somebody has said hydatid cyst.
Okay, very good. Hydatid cyst. But hydatid cyst where? You see, this is the uterus. These are two fallopian tubes. This is obviously inner pelvis, true pelvis. Now, that is in there also. Then this is obviously much below the liver. This is the region of the liver, you see. Now,
the other possibilities mentioned is intestinal tuberculosis and phlegmon.
No.
This phlegmon is a term which is now obsolete almost.
Now tell me, I'm showing you. Yes, somebody is trying to.
Dr. Usha Datta has joined us. Let me introduce Dr. Usha Datta. He is the head of gastroenterology at prestigious VGI in Chandigarh. I am Meter and so Dr. Usha Datta. So welcome, Dr. Usha Datta.
Thank you. Thank you so much. It's a pleasure to be a part of this meeting, and Dr. Ghoshal has been conducting it very well. I just wanted to tell the residents who are participating, even if you try and describe this lesion, there is a solid component which is enhancing, and there is a fluid component which is all around. So does that give you some clue in this patient?
Yeah. So now why I'm trying to tell you is, what I'm trying to tell you is clinical medicine is like this. So suppose when you want to be a researcher, you have to go deep and deep and deep inside one area. When you have to be a clinician, you have to have tremendous width. You may not have depth, but you have to have width. Now here you see, we are showing you something. Whole abdomen is having fluid. Look at this. Fluid here. Fluid here. Whole abdomen is having fluid. Now second thing what I'm showing you is that look at the Hounspool unit of the fluid, 45. Okay, and one more actually picture I don't have. Actually, there was scalloping in the liver. So here is a patient who has scalloping in the liver. This I do not have the image. You have fluid which is of high density, and it is free fluid. This is inside the peritoneum. So what is the diagnosis now? I'll tell you. So now we obviously did a colonoscopy, right iliac fossa lump colonoscopy is done. Now it's normal. Now this is what we did. We aspirated and put this ascitic fluid on the table, and this is jelly-like. So what is the diagnosis? pseudomyxoma peritoneum.
You can write your diagnosis. Whenever Dr. Goshal is saying something, please write your diagnosis. You can.
He has, with his last word which he has used, he has given the diagnosis.
Now, what I'm trying to tell you is that if you are in an exam, we do not want you to write pseudomyxoma peritoneum. I tell you. What we want is the approach to the lump. Is it intraperitoneal or peritoneal? Right iliac fossa intraperitoneal lump. So obviously, what could be the causes? It could be arising from ileum. It could be arising from appendix, because appendix is normally intraperitoneal, except 1% it can be retrocecal appendix, which is retroperitoneal. Normally, cecum is retroperitoneal, but some patients cecum can have mesentery. Like such variation is well known. So it can be from cecum, it can be from appendix, it can be from ileum. Now you know appendicular tumor. What are the causes of pseudomyxoma peritoneum? Appendicular tumor is classically known to produce pseudomyxoma peritoneum. Second thing is that gallbladder can rarely lead to pseudomyxoma peritoneum. Stomach cancer can lead to pseudomyxoma peritoneum, and colon can lead to pseudomyxoma peritoneum. See, typically those which produce mucin, they tend to produce pseudomyxoma peritoneum. But if you miss the diagnosis, no problem. In fact, if somebody tells the diagnosis, examiner will be suspicious. The diagnosis might have been leaked. But your approach to a lump in the right iliac fossa, which is intraperitoneal in nature, and you can tell all those, that is enough. So when somebody says tuberculosis, I don't mind that, because yes, tuberculosis can have a lump. 5 to 10% patient with tuberculosis can have lump. Okay. Now patient has intestinal obstruction twice. Patient of intestinal tuberculosis may not have fever. In fact, 25% of intestinal tuberculosis, GI tuberculosis have fever. Maybe 60 to 70% don't have. So our patient did not have systemic symptom. Remember one thing, free ascites in patient of GI tuberculosis are uncommon. So what happens is peritoneal tuberculosis and GI tuberculosis do not normally coexist very frequently. The percentage of two being together there as clinically manifested involvement is only 15%. But still 15% is a big number. So tuberculosis is granted as a differential diagnosis. But because this was an interesting patient, that's why I made this slide. So tips. What I would tell you is see and discuss patient in the evening among friends. And when you discuss, you always read, like a lot of my slide I made from a surgery book called Mangot. So that is a very good book for retroperitoneal lump, intraperitoneal lump differential diagnosis. Make a copy with practical tips. Copy book, I'm trying to say copy book. Make a copy book. Like all these retroperitoneal, intraperitoneal, you should have this table ready in your copy book. That's why I'm trying to write that book, so that you don't have to write in your copybook. The book will have all this. Dream those tips, see those tips, practice those tips. You know why? Because it is very easy. In clinical medicine is like backward walking. So what happens is, it is very easy if I say, can you enumerate 10 differences between intraperitoneal and retroperitoneal? Many people will be able to answer. But when you get a patient now backward walking and telling whether it is retroperitoneal and intraperitoneal, what could be the diagnosis becomes difficult. Read Hutchison. And remember one more thing, all of you have knowledge, you read a lot, you have come through so many MCQ exams. Having knowledge is good, but being able to apply in bedside is not as easy as having knowledge. Thank you so much. Any question, I'll love to answer.
Thank you, Dr. Goshal, for an excellent demonstration of how to assess the case. And Dr. Goshal has been a part of teaching a lot of postgraduates for a very long time. The few things I would like to add to what Dr. Goshal has already said. First of all, when you take a history and do an examination, do not look at the CT scan or the investigations of the patients. When you're spending these next 2-3 years in your DNB, Don't look at the investigation. So then every patient becomes a learning exercise. That is one thing which you can do. Second is when you're examining the abdomen, look at it three-dimensionally, not just which quadrant the lump is, but what plane the lump is. And thirdly, mobility of the lump should be not only with respiration, but also the inherent mobility of the lump, right to left, as well as up and down. So that mobility tells you what is it fixated or is it attached to an intraperitoneal structure. And the third thing I wanted to add here was the ballotability, which Dr. Ghoshal was trying to say. Ballotability usually means that there is a pedicle, like the kidney usually has a pedicle. So that's why when you push it from, posteriorly, it will come and hit you and come back to your hand. So classically, anything which has a pedicle is a ballotable lump. And another point which I wanted to add was in the puddle sign. It is actually difficult in a knee elbow position to do the classical puddle sign. So just a scratch test with your ausculto percussion helps you in picking that up. And Dr. Ghoshal has wonderfully demonstrated how to analyze a patient who comes with intestinal obstruction and has a lump, and how to integrate the findings of clinical examination with radiology and come to a diagnosis. So we can open this for discussion, and you can put your question in the chat box.
Okay, very good. So there is a question somebody asked, what is the pathophysiology of duodenal ulcer pain post-meal? Now let me tell you, this was an elegant study published in Gastro quite some time ago. So what they did is they took a dual channel pH metric catheter. Now what they did is they put that catheter, one port was in the duodenum and other port was in the antrum of the stomach. And the patient had patient has duodenal ulcer. Now what they did is they asked the patient to report pain by visual analog scale. Obviously, 24-hour pH metric recording is going on. One port is recording the duodenal pH, other port is recording the gastric pH. Okay. Now what happened is when the fellow actually took meal, his duodenal further acidic. Okay, that is, there is no reason why duodenal pain or duodenal ulcer pain should get reduced after meal, because we all know after eating, even when I try to eat, when I see food, when I smell food, my gastric secretion increases, and when gastric secretion increases, the acid goes to the duodenum. Now what happened is that after eating or during eating, the duodenal pH went down, but the patient had relief in the pain. What happened is, what they found is antral pH went up after eating. The reason is that when you eat, actually food acts as the buffer. So antral pH went up. And in that study, all patients had antral gastritis. So this author, based on these findings, showed or suggested it is the antral gastritis which is the reason for duodenal ulcer pain, not the duodenal acid alteration or duodenal nerve ending being sort of bare and therefore all those relief. So the relief is related to the food bathing the antrum and neutralizing the stomach acid. So that is the pathophysiology. Now somebody asked, what is the importance of constipation versus obstipation? See, obstipation means the fellow is not passing flatus. The fellow is not passing feces. Now, what you have to understand is that means there is a very tight obstruction, very tight obstruction. Now, obviously, I told you lower gut obstruction typically tend to have more bowel-related symptoms such as constipation and obstipation, not the upper gut obstruction. Like gastric outlet obstruction will not have constipation so much than a colonic obstruction. And obviously, obstipation means there is a tight narrowing. But many a time you give a negative history, like you say, patient had pain of 2 hours. And you say there was no constipation and obstipation during the pain. This is difficult. You know why? Because who defecates every 2 hours? Normally people defecate maybe once in a day or twice in a day or thrice in a day. Now, question is in 2 hours, that negative history may not mean anything. That negative history may not mean anything. But if there is an obstruction of sufficient duration, pain of sufficient duration, abdominal distension of sufficient duration, then you talk about constipation and obstipation.
I think, thank you both, Dr. Usha Datta and Dr. Uday Ghoshal. One or two questions, Uday. What about mesenteric lump mobility? How do we describe the mesenteric lump mobility? And the second question which I have for you to tell the students that find out a lump in the right iliac fossa. So when you reach a diagnosis, how should you approach? Whether you should talk about then the pathology of that organ, and how should you proceed? Should you, like some people commented, intestinal tuberculosis? So it doesn't mention that when you talk about intestinal tuberculosis, you're not talking about the organ of the intestine which is involved. So how should a diagnosis be made in the clinical bedside when you're dealing with a lump? You talk about the organ first, then you talk about the inflammation or etiology, and how do you proceed?
Yeah, I'll take up the second question first. This is a very important question. You see how neurologists make the diagnosis. A gastroenterologist should make similar diagnosis. Like in our patient, we will say abdominal, then we'll say, or maybe right iliac fossa lump, then we'll say intraperitoneal. Plain is intraperitoneal. Then we'll say that maybe it is benign. More likely than malignant, because she did not have any constitutional symptom, she did not have much anorexia, she did not have much weight loss. So you make a mistake, no problem. But what I'm saying is, so first you talk about the lump, talk about his plain intraperitoneal, retroperitoneal, then you talk about the malignant, or then you talk about which organ you are suspecting from where the lump is coming. Are you suspecting it is from ileum? Are you suspecting it is from appendix? Are you suspecting it is from cecum? Or are you suspecting it is from tubo-ovarian? Now, when you talk about tubo-ovarian, remember one thing, tubo-ovary actually remains in the plane of true pelvis. So therefore, I did not tell you in the lump. See, we could reach below the lump. If you reach below the lump, if you insert your finger below the lump, that means it can't be tubo-ovary. Okay? Okay, it can't be tubo-ovary. So therefore, we'll say this is a lump arising. It is a lump which is intraperitoneal in the right iliac fossa. The origin could be from the appendix or the ileum. However, origin from the cecum is possible. There could be a mesentery in the cecum, which is not uncommon. I would say this lump appears to be benign. And then you give an etiological diagnosis. List multiple etiological diagnoses so that your net is wide enough that you can catch all the pieces. So that is the way you diagnose rather than saying intestinal tuberculosis. That is absolutely wrong way of making the diagnosis. We are not asking pathological diagnosis. We are asking for anatomical diagnosis. Anatomical diagnosis will include plain, then the organ, then the benign malignant, and then the pathology. And your first question was, sorry, I missed.
Mesenteric lump.
Yeah, mesenteric lump, typically I'll tell you that the classic is if you draw a line in the direction of mesentery, that is from the spleen on the left side and the right iliac fossa on the right side. Now you draw a line. Now the mesenteric lump will have good intrinsic mobility, but this mobility will be diagonal to this line. If the line is on this side, the movement of the lump will be to the other side. That is from right to left and left to right. So that is a mesenteric kind of movement of a mesenteric lump moving or the direction of mesenteric lump moving.
See, one more question is that all these intraperitoneal versus retroperitoneal versus mainly intraperitoneal versus retroperitoneal, once the lump increases in size, the retroperitoneal gets some components of the intraperitoneal, some characteristics of the intraperitoneal and vice versa. So in a large,
good question. I tell you, all these applied, all these feature applied when you have a relatively smaller lump. Let us say a lump started in the retroperitoneum and now it became so big, like a football, it will have extension to the intraperitoneal component. Therefore, though it is the retroperitoneal in origin, the percussion note is dull. Okay, it may even be sort of superficial in nature rather than being deep. So in that case, you can say the lump is too big to differentiate from intraperitoneal to retroperitoneal. And many a time history tells you, like if I remember I had a patient which had a big lump like this. Now this patient started with a radicular pain. So I justified that this lump originated from the retroperitoneum because her symptoms started 1 year ago with a radicular pain. So radicular pain means originating from the retroperitoneum. And on surgery, they could diagnose this as a retroperitoneal sarcoma and it really started in the retroperitoneum. So they you talk about intraperitoneal lump and retroperitoneal extension, retroperitoneal lump.
So there are two quick questions on the chat box and the Dr. Usha type you can take. Are the colicky pain and cramping pain describing the same nature of pain? Colicky versus cramping. And abdominal migraine. What are the features of abdominal migraine? And what happens to DD in the of abdominal lump in pregnancy? How do we change our approach? I think short answers because we have just 2 more minutes.
Yeah. So abdominal migraine typically has recurrent abdominal pain. And quite often, that there are no abdominal signs. Typical absent abdominal signs, and these pains occurring repeatedly and all investigations coming negative is suggestive of an abdominal migraine. Bleeding can be done during pain, but we rarely actually see a lot of abdominal migraine. It is you suspect it when clinical examination is completely normal. The other things you should suspect in such a situation is an internal herniation, lead poisoning. So these kind of rare diagnoses are entertained in patients who have recurrent abdominal pain, but who on clinical evaluations as well as CT have no obvious things coming up. So the second question is related to
abdominal lump in pregnancy.
Sorry, come again, please.
Abdominal lump in pregnancy.
Abdominal lump in pregnancy can often cause problems depending on the trimester of pregnancy. So all our clinical understanding of these lumps do not stand during pregnancy. So the best way in such a situation is to understand an ultrasound or an MRI for finding out what is the cause of this lump. But the dictum is that a CT scan is safe in pregnancy and it is going to save the mother. After the first trimester, if the patient comes with a significant problem, then also we can preferably do an MRI because that is safer. Clinical examination can be fairly suspicious in such a situation. You can use ultrasound by a good ultrasonologist.
So the last question is: can we replace cramping pain? Are they same? Colicky pain and cramping pain.
Yeah, so colicky pain suddenly goes up, stays and comes down. So it doesn't last for more than 1 or 2 seconds. It comes down. So colicky pain and cramping pain are actually more or less similar in our understanding. It usually arises from the luminal organ. And there is a sudden contraction and that results in pain and it releases. The only misnomer to that is biliary colic, where it is called a colicky pain, but it rises over a period of time, lasts 30 to 40 minutes and then subsides. So that is a misnomer. Otherwise, colicky and crampy pain can arise from the gut.
Cramping pain is, the difference is severity as well, that we don't describe a severe pain as a crampy pain, we describe a mild pain as a crampy pain.
Yeah, but crampy is a colloquial way of saying it, but actually, technically, it is either colicky pain or a dull aching, constant pain.
Okay, so I think we will. If you are there, then you need to unmute yourself. Yes, Dr. Usha.
Yeah, I just wanted to pass on one message to all the DMB students that when they history before they touch the patient, write the differential diagnosis based on the history. Because quite often in the exam, they'll ask you what are your differential diagnoses after history. Second is anticipate what are the examination findings you're going to get in that patient. Then it is more easy to understand and interpret the examination. Third is examine before you see the CT scan of the patient. So then you learn from every patient. So these are the 3 tips I wanted to tell our residents. And we are happy to take anything on email. Or my email is usha@gmail.com.
So thank you, Dr. Usha Datta. I think we have lost connection with Uday, but we almost finished. Let me tell you, do you want to make a last comment?
Okay.
Comment.
It was a pleasure to share this important clinical topic, and I tell you that these are the most important things in your exam. So it is a pleasure to discuss a topic which is of your exam importance, and we wish we can discuss more and more such topics.
So we already let me just thank Uday and Dr. Usha Datta once again. I got 2 clinicians for this meeting. I have already spoken to a number of other senior faculty all over the country, and what I intend to do is that after third, when exam people are preparing for the practical exam, there will be many such case-based discussions which are going to take place. I've already talked to Dr. Jayanti, Dr. Krishna, so there will be a number of such sessions. Next week, we will have a surgeon speaking about liver transplantation. So Dr. Ramdeep Roy, who is a liver transplant surgeon in Calcutta, is going to speak to medical gastroenterology students what non-surgeons should know about the surgical components of liver transplant. So next Monday at 6 p.m., please tune in for the next session of online DNB classes. Navneet, it's all yours.
Thank you very much, Dr. Uday, for the presentation, and thank you very much, Dr. Gupta and Dr. Mahesh Goenka for joining us. Thank you, students, for joining us.
Thank you.
Thank you.